For asking me to speak today. It's really lovely to see so many of you who've come along today. I was asked to talk about working with your Hepatology Nurse Specialist, which I think is perhaps a bit of a joke, but we might get to that in the end. So the aims of the session was just to understand the role of a hepatology specialist nurse. How can it work for you? And what do you want from a hepatology specialist nurse? So although you're all sitting in the dark, I will be asking you some questions a bit later on. So I'd like you to give me back some answers as well. And just how we can perhaps move things forward in the end. So the role of the hepatology specialist nurse, it varies across the country, but was initially developed to look after specific diseases and supporting patients through treatments. And that was mainly, firstly, with alcohol liaison nurses, so sort of identifying and supporting patients trying to stop drinking. And they're now currently working across primary and secondary care to improve access to detox and managing the complications of liver disease, such as ascites, variceal bleeding, and hepatic encephalopathy. And for example, in Nottingham, they have community matrons who regularly text patients who've got ascites to monitor their weight so that they can plan to bring them in for paracentesis. So the next sort of group of specialist nurses in hepatology were our viral hepatitis nurses, and they were supporting and helping patients to complete courses of therapy to eradicate the virus. It was a difficult regime, and patients had complex needs and needed close nursing support to get through the treatment. But now there are now better therapies coming through with better outcomes for those patients, but now a wider remit, such as managing complications of the liver disease in that nurse-led group. They're also working across different hospitals and settings, such as the homeless and prisons, and they're trying to find novel ways to engage with sometimes a difficult patient group to ensure they get treatment. So the role now, though, is becoming much less attached to the disease itself and to all patients who have any liver diseases. And we're much more working with the patient and what your particular need is rather than a disease process. So now we can offer things such as stable cirrhotic clinics where we monitor patients every 6 months with an ultrasound blood test and see how they're doing, looking for cancers or changes in their liver disease so that we can implement treatment sooner. We can support and give information about PSC or your liver disease, can monitor you for some of the complications such as ascites or bleeding from varices or the development of hepatic encephalopathy. And at the end of life, we can also be involved in planning for end-of-life care. So the stable cirrhotic clinic is a clinic where we see people every 6 months. They come from any type of liver disease. So if you had PSC, you might be in that clinic. And I've seen a few of you who are here today. And we are monitoring you for any changes in your blood tests. We're looking at you as you come into the clinic, just seeing how well you are, whether there's been any changes in your condition, and also looking at your blood tests to see whether those have changed. And again, we're trying to pick up any complications early. We're shared with the consultants, and I technically work for 13 consultants, but there are 3 clinics across the week, and although the Monday one is supposed to be the stable cirrhotic clinic, I sometimes keep people in the same clinic day as they see their normal consultants so they don't have to change around. So it's a consultation, it's blood tests, as we've said, an endoscopy, either 3 yearly if there weren't any varices seen at the last one, or if there were varices seen then every year, and an ultrasound. So in the nurse-led hepatology clinics, which are slightly different, then I'm seeing some patients who've got have some of these complications. So there may be people who we're trying to increase their beta blockers, so we're changing their medications. There may be people with autoimmune hepatitis that we're managing their prednisolone and different medications. We're reviewing patients with ascites and leg edema, managing the response to diuretics, giving them information about diet and how to manage their ascites, and also helping to plan if we need to bring them in for a drain. I manage some patients who've had episodes of hepatic encephalopathy, which is a sort of brain fog that you get when your liver's not working well. And often that's quite difficult to manage, so they need a little bit of education, and it's important to involve their family and carers in that education so that they can recognise it and start treating it earlier. And the clinic goes on, so we're trying to support you and give information to the patient and the family, particularly when you've firstly been diagnosed. I think we know in our hepatology world, we're not very good at explaining what cirrhosis is to people or to what some of the complications are. are. Some of the patients who've come to the stable cirrhotic clinic have told me that they were really worried coming to see a nurse because they thought that they were so poorly the doctor had given up on them and he couldn't do anything else for them. In fact, they're actually our wellest patient group, and we hope to keep them very well for a long time. So I think it's really important that we explain what cirrhosis is. We're also signposting where you can get more information. So for PSC, it would be to your support group, but there's also the British Liver Trust has good information for other liver diseases as well. We'll also have a telephone contact, so we're your point of continuity. Come and see us, get to know us. You can phone us up, we can ask us questions, and we'll usually be able to get it sorted out and help you. I also manage some patients with hemochromatosis, and they have weekly venisections. We monitor them until that gets reduced, and then we put them into the blood transfusion service. We provide support at end of life if needed, so identifying patients when this is occurring and referring them to palliative care, but also carrying on that support with the people they've known for quite a long time in the Royal Free. So I haven't forgotten that you've all got PSC. So you've got PSC, but not cirrhosis. So what can I, the CNS, offer you? It's always good to have a contact, a name and a face for any problems in the future. You'll still need a yearly scan and follow-up, even if everything's stable. You may need to get more information about PSC and want someone to talk to about your symptoms, fatigue and weight loss, psychological support, pruritus, which is a difficult-to-manage symptom, osteopenia supporting your bones, and vitamin D deficiencies as well. So if you're on a yearly follow-up with your consultant, there isn't any reason why you couldn't see a nurse at 6 months if you felt you needed some extra support. You may have a flare of cholangitis, and the CNS can give advice about antibiotics, hydration and pain relief, as well as the need for further scans, such as an MRCP. You can support and information for your family about the regular cholangitis, having an awareness of the risks of developing cholangiocarcinoma, and signposting where to go, and linking with GPs and other agencies. So, working with your hepatology CNS, how many of you have a liver gastroenterology nurse involved in your care, apart from an IBD nurse? If you can. I did tell you it was going to be a bit of an oxymoron joke, wasn't it? So none of you do have any access. One, lovely, excellent. Anyone else? I can't see at the back. Sorry, we're all in the dark. So would you like to have access to a hepatology specialist nurse? Yes. Okay, brilliant. And how can we then improve your access to us? I think there are some barriers, aren't there? So sometimes when you're coming, you may not know that your centre or your hospital has a specialist nurse, so you perhaps need to ask if there's somebody who's a hepatology specialist nurse that you could see. You might need to be introduced in the clinic. I am in the Monday clinic with Dr. Thorburn and Dr. Marshall, so you can come and knock on the door. Maybe you don't know where specialist nurses live, or telephone numbers or contact numbers. You can ask your consultant. But maybe we also need to identify and develop a shared protocol between hepatologists and CNSs about who they can manage and access to the CNS for all the information and support they need. And I would say that we can support you. We have expertise and knowledge and experience of working with patients with the same complications that you have. And many of the symptoms and complications of liver disease are the same as other patients with liver disease. And we should be available in the trust to be part of the MDT caring for you and PSC patients. So you need to lobby your centres for access to your hepatology CNS, including me. Thank you.